good afternoon. I'd like to welcome and introduce Dr. Robert Murphy, Executive Director of the Robert J. Havey, MD, Institute for Global Health, and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine, who answers your COVID questions every Tuesday and Thursday here on the Havey Institute for Global Health's Facebook page. And today, Dr. Murphy will be answering viewer-submitted questions and addressing the latest COVID news through today, the 3rd of February. And we invite you to continue to submit your questions to us via Facebook at NU Institute for Global Health or via email at globalhealthinstitute@northwestern.edu. And leading the discussion again today is Sophie Biskowski, a student research assistant with the Institute. So Sophie, I now turn it over to you.
Thank you, Kristen. Hi, Dr. Murphy.
Good morning.
So for some exciting news, although the numbers are still very high, we are seeing a 49% decrease of overall cases in the United States. Our 7-day average as of yesterday was 385,000. And yesterday in the States, we saw 324,000 new positive cases. Hospitalizations have also decreased by 16%. And unfortunately, deaths are now increasing by a lot. Deaths have increased by 35% in the last 2 weeks. In Illinois, we are also seeing a massive decrease in cases. Yesterday in Illinois, we saw 9,427 with our 7-day average of about 10,327. And we are seeing the death rate and hospitalization rate both decreasing in Illinois, which is great news. What can you tell us about the death rate increasing by 35% in the last 2 weeks?
Yeah, this is not surprising. The people dying from COVID is the last metric to improve, because let's look at the timeline. A person gets exposed. About a week later, they get symptoms, and then they're either going to get better over the next week or two, or they're going to get sicker and end up in the hospital. So a significant smaller percentage, like 10% or so, end up in the hospital. Of those people in the hospital then, so now we're already out a couple weeks, some of them deteriorate and go into the ICU. And then once they're in the ICU, they get all sorts of, ventilator support and other and very intensive treatments. And they can stay in the ICU for months. And ultimately, some of them will pass away, unfortunately. So by the time all that happens, it's many weeks. So the first thing that happens as the pandemic gets under control, like it is right now, the case numbers really drop, and they're dropping really steeply. Just like they went up steep, they're coming down steep, just like this has been seen around the world. So you have the case numbers down. When the case numbers are down, the next thing that happens is the hospitalization rate goes down, and that's just starting to happen. It's either not increasing as much, or it is actually starting to decrease. And once that goes down, the ICU rate goes down. And then finally, when the ICU is not so full of COVID patients, the death rate goes down. So we're still seeing those patients that were infected during the upswing of the wave. They're the ones that are unfortunately in the ICU, not doing well, and some of them are passing away. So it's the last metric to improve. But it's just very good news that we're now on that steep decline part. So that very high peak, more than we've seen anything with this pandemic, and now it's coming down almost as fast as it went up.
Yeah, absolutely. Speaking of, the cases decreasing, some good news is that over 60 million households have requested free COVID rapid tests from the White House administration. Last week we touched on that the White House was providing these free COVID tests, and now 60 million of them have been requested. What can you tell us about this?
Well, it's great. It's been difficult to get a hold of these tests. And they're probably going to get out to the houses just as the pandemic is on the downswing. But now if there's any question, the tests are available. These are rapid antigen tests that are being sent to the homes. You have to look at, there's different ones being sent, and most of the ones that are out there, with like just 2 exceptions, the Elum and the Orchard test, have been designed really and approved only for people who have symptoms. So if you do get sick, you have sniffles, cold, cough, sore throat, whatever, you think you have a cold, or you think you might have the flu, that's when these tests should be used. And now, a lot of people will have them at home because they had requested the test and they're being delivered.
Right, absolutely. And now for our second COVID headline, Dr. Murphy, what do we know about the BA2, the newest COVID Omicron?
Well, we're learning more every day about BA2. So this is the stealth Omicron. So we got, infected with the Omicron right after Delta. And that is much more transmissible. And that's what caused this huge peak. And it overtook everything. And then that has 53 mutations. So you throw a couple more mutations or different mutations on there, and it goes from BA1, which is the original Omicron, to BA2, BA.2. And it appears to be outcompeting BA1. And several European countries, like the Danish, I think it's about 50%. And in other countries in Europe, it's like 5%, but it's increasing. Now, it's behaving the same. So it's not that different. It's not a new variant of concern, really. It's they call it the brother or sister of BA1. It's very similar. And they don't think it's going to behave any differently from the other one. But it may be a little bit more transmissible, easier to transmit, because we're seeing, it looks like it's taking over in some places.
Right, absolutely. And those were all of our COVID headlines. And now for some COVID questions. For the first one, my employer is using the term, quote, up-to-date vaccinated instead of, quote, fully vaccinated when discussing COVID-19. Why is the different terminology being used between different states, different countries, different local governments, and different workplaces?
Well, it's just because the system here is that the states actually control the health. The federal government can give guidance. The federal government can provide funding, like in Medicare and Medicaid and the Veterans Administration, but they can't actually really direct health. The terminology is all semantics right now. The terminology is that fully vaccinated is for the Pfizer and Moderna, the 2 shots, or the Johnson & Johnson, the 1 shot. That's considered fully vaccinated. And then if you had an additional shot, like this 3rd shot for Pfizer and Moderna, that's what we're calling a booster. That's what I think this term up-to-date vaccinated refers to. And especially with the Omicron and with the Delta variants, the boosters really play an important role in keeping people out of the hospital and out of the ICU and keeping them alive. I mean, by a dramatic amount, 20, 30-fold difference between those that are unvaccinated, or even against those that are partially vaccinated, or it's actually not partially vaccinated, now it's fully vaccinated. So it's a little bit, it's semantics. It's a little bit confusing, but the up-to-date vaccinated is with the booster, 1 booster.
Right, wonderful. You touched on this a bit before, but can you explain why there are so many more deaths being reported, even though the positive numbers are going down? It's
hard to get your head around why the death rate takes so long. The reason is that once a person gets in the hospital, they can be there for months. They're on ECMO, they're on ventilators, they're getting all sorts of treatments. And, we can really support people very well once they're in the hospital. They may not make it. I mean, we've even done lung transplants in people whose lungs were just torn up from COVID. And so they can stay in the hospital for months. Meanwhile, the peak has gone down. So the number of cases is down, number of new people in the hospital is down, but we're keeping those people in the ICU in particular alive longer. And so, ultimately they're either going to get better or they're going to pass away, unfortunately. And that's why you see it so late. So it's the last metric that improves. When that starts to improve, that's a really good sign. That means that whole wave has really passed through us.
Right, absolutely. And now for this third question that, my apologies, is slightly confusing. This mother who wants to give her child Pfizer would like to understand why a 4-year-old, an 11-month-old, and a 30-year-old needs 3 shots, but someone from the age of 5 to 11 only needs 2 shots. So why are there different shots for different age groups?
Well, remember these are coming for kids. It's emergency use authorization, and they're making these recommendations based on the best available data at the time of the approval. And so, they don't know if kids are going to respond better or worse to these vaccines. And so when they got their approval, they got approved as the 2 shots. Let's forget about Johnson & Johnson. It's not really used in kids. So the Pfizer and the Moderna got approved with the double dose 3 or 4 weeks apart, or the 2 doses 3 or 4 weeks apart. And then as those kids were followed, the kids 12 and up were found to actually lose some of the protection from the vaccine. And so a 3rd shot, the booster shot, was approved in the group 12 to 17 to catch up with the adults. So they're from 12 and up, they're just like the adults. You get the 2 and then you get your booster and you have much more protection. Under 12, it's still just 2 shots. Pfizer has applied for the 2-shot approach in kids 6 months to 4 years of age. That's pending, but they're applying for the 2 shots, and still also the 5 to 11 group is still just 2 shots, but that may change. And that's all just like, rumor, I guess. I don't know. I'm just reading it in the newspaper like anybody else. So that's why there is this kind of stepwise fashion. They want to see the safety, and they want to see if it's actually really needed. We'll see. Probably they're going to have a 3rd shot, most likely. I mean, that's the way, a lot of vaccines are developed, with the initial 1 or 2 shots and then a booster like 6 months later. That's very classic with vaccines. And it's also classic, and it's also the approved regimen for the adult doses now, where it's actually 5 months where they give the booster after the 2nd dose. So it's 6 months total, because they get dose 1, then about 3 or 4 weeks later, dose 2, and then 5 months later, or 6 months from the first one, they get their 3rd shot. And then whether we're going to need a 4th shot or annually or something like that, we don't know. But the final optimal vaccine schedule is forthcoming. We're in the middle of this thing. All this stuff got approved under emergency use authorization so that people could be protected before the full approval. But Moderna's fully approved now. Pfizer is fully approved in adults anyway, and it's working its way down as we get more and more data on the younger populations.
Right, absolutely. And now for our last COVID question. Since the CDC counts anyone with COVID who dies a COVID death, not necessarily someone who died from COVID, what do you think the real mortality rate is, Dr. Murphy?
Yeah, no, this is a really good question, and it's a really complicated question, because there's a lot of scenarios. First of all, when somebody is in the hospital, first of all, when you come to a hospital, you get tested for COVID, and no matter if you're coming to have a facelift or something. I mean, everybody is tested for COVID. So they pick up a lot of people who aren't there because of COVID. And then that is a state by state mandated to be reported to the state health authorities. So all the COVID, whether it's incidental or they're coming in with full-blown COVID pneumonia, it all gets reported to the state. Now, if a person is admitted to the hospital, they have COVID, and they die, they're going to get reported as a COVID case. So this is true. So there could be some over-reporting there. However, the reporting by the states on the death certificates varies from state to state. So it's really hard to kind of make any sense out of it. So the scenarios are this. You come in with classic COVID pneumonia, and you're really sick and you die. You died from COVID, all right? You come in because you were in a car accident, had nothing to do with COVID, but they test you before you die and you have COVID. That person didn't die from COVID. The person died of a car accident, right? So you have those two extremes. Then in the middle, you have a person who comes in because they had a heart attack, all right? Leading cause of death, or maybe they had cancer or something like that. And then they were found to have COVID while they're there getting treated for their other serious medical problem. Now, in that middle group, it really can go either way. Was the COVID incidental, or did the COVID trip them, make them just even that much worse, and that caused the death? So that middle group is a plus minus. It can go kind of either way. It's very hard to sort that out. So in the big picture, what has to happen is you look at, we know we have history of how many people die from each disease every year. And prior to COVID, there were 2.8 million deaths per year. So you look at the death rate, the age breakdown, and the underlying diseases, and you can come up with all sorts of ways to present the data to see if COVID is really contributing to the death rate. And it certainly is. I mean, there is no doubt about it. COVID has negatively impaired overall survival. You know, people are living almost 2 years less than before, and over 800,000 people have died with a COVID diagnosis. Most of it is because of actual pneumonia and the disease that COVID caused. But there are certainly these other incidental or partially related cases that are in there. And another thing to make it even more complicated, because of COVID, people are not going to the hospital as much. They're not doing their preventive mammograms or colonoscopies or getting treated for their other diseases. And those diseases are getting worse, and their death rate from those diseases has gone up as well. So it's a really complicated question. I mean, the answer to that question is very complicated to explain. So yes, COVID can directly cause mortality and indirectly contribute to mortality. But make it perfectly clear that a lot of people are dying from COVID. You go in the hospitals now, you go in the ICU, the number of COVID patients that are sick and on ventilators and ECMO and everything else are really, really taking up a lot of the resources in this country. And it varies, of course, by region and county and whatever. But don't underestimate how lethal this disease is. But that's a complicated question, and it takes really quite a while to figure out the exact or the best answer to that. When these statistics get crunched by the CDC, it really, the full reporting doesn't come for over a year after that year has ended. So like right now, I was looking up the results here, and the last really good year for all that stuff was 2019. So, we'll be seeing the 2020 more hardcore look at the data shortly.
Right. No, absolutely. Well, those were all of our COVID questions for today. Thank you, Dr. Murphy.
All right. Thank you. Have a great day.